Okay, welcome everyone to this VCCC Breast Cancer Education Series. Before we start, I'd like to acknowledge the traditional owners of the land on which we're all participating and pay respects to their elders past and present and emerging. I'm really pleased and looking forward to this session. I was just saying to the panelists that over recent years I've become completely converted to the fact that imaging has far more to offer than is sometimes recognised, and I think the more one gets into it, the more one realises how true that is. We've got 3 talks today. First is going to be on PET, the second, and that's from Zithing Lee. Second is from Kenny Elder, who's going to talk about issues on imaging around neoadjuvant therapy. And then we're going to hear from Jenny Ellis about contrast enhanced mammography. We'll have some discussion after each, hopefully we'll have some time. So with no further ado, Zithing will tell us all about PET scanning.
Thank you very much, Bruce, for that introduction. Okay, can everyone see my screen now?
Yes, we can.
Great, thanks. So thanks for the introduction and also the invitation to, from you and Belinda to actually present on PET CT in breast carcinoma. And as Bruce, when Bruce brought it up with me, he had a few specific questions that he actually wanted answered. And so I hope that I'll be able to do that with today's talk. And this will be what I'll be covering today. As most of you would actually know, FDG PET in breast cancer was actually finally approved by Medicare in November 2019, and that is for the staging of locally advanced breast cancer and also for the evaluation of suspected metastatic or local or regionally recurrent breast cancer. I would say that we are somewhat of a delayed adopter of PET in this investigation paradigm of breast cancer, which has actually been used internationally for almost a whole decade. So as you all know, accurate staging is crucial to determine the optimal treatment approaches, both at initial presentation and also in restaging following treatment. And in fact, at initial diagnosis, approximately 45% of patients can have stage 2 to 4 disease. But traditionally, the staging of newly diagnosed breast cancer and even for repeated staging is with conventional imaging tests such as CT, MRI, ultrasound, and whole body bone scans. But as of November 2019, FDG PET has now been put into the mix. So in terms of the role for PET in early staging and sentinel node biopsy, for staging of early breast cancer, the identification and sampling of the sentinel node is the standard of care because FDG PET is really quite limited compared to sentinel node biopsy, which is still deemed as the gold standard. In a prospective evaluation comparing PET sentinel node biopsy and axillary lymph node dissection in patients with early stage breast cancer, found that the sensitivity of PET was only between 20 to 50%. And you can get false negative PETs in small sentinel nodes, and of course false positive in inflamed nodes as well. The use of SPECT-CT, which is a 3-dimensional image acquisition from the sentinel node scan, did have better localization, especially for deep lesions, and was found to be superior to blue dye labeling during surgery. This is an example of the potential use of PET in nodal identification, not so much in axillary nodal staging, but actually for metastatic nodal involvement, such as the internal mammary nodes, which can be seen in up to 25% of patients with locally advanced breast cancer and is predictive of the likelihood and pattern of treatment failure as well. In patients with locally advanced breast cancer, PET-CT did detect distant metastasis in 45% of patients compared to 25% in conventional imaging on this particular study. And it also upstaged the disease in almost 50% of patients compared to 20% in conventional imaging. And that's due to the identification of additional sites of distant disease. So the main advantages really of FDG PET is to detect the unsuspected distant metastases and the extra-axillary lymph nodes that are not routinely sampled, and was actually found by a large study in America to actually change the initial staging in 42% of patients after conventional imaging. This is such an example from one of our patients here who had left breast carcinoma with normal CT and whole body bone scan. And you can see the left breast primary with ipsilateral axillary nodes. And unfortunately for the patient, she did have quite diffuse bone marrow uptake that was biopsy proven as being ER positive metastatic breast cancer. But what I do want to point out is that there is a difference between invasive ductal carcinoma and invasive lobular carcinoma patients, where the impact of PET-CT on the systemic staging may be lower for lobular carcinoma than ductal carcinoma patients. In this particular study, it looked at head-to-head comparison of stage 3 ductal and lobular carcinoma patients, and 22% of patients with invasive ductal carcinoma were upstaged to stage 4 compared to 8% with invasive lobular carcinoma. And the relative risk of PET-CT revealing unsuspected distant metastases in ductal carcinoma was actually almost 2 times that compared to lobular carcinoma. And for FDG-avid metastasis, there was almost a 3 times increase detection rate compared to invasive lobular carcinoma. This is an example of one of our patients with triple negative breast cancer, which is one of the types of breast cancer that does tend to be most FDG avid. And in this particular patient, not only is the primary intensely FDG avid denoted by the arrow there, but also with the ipsilateral axillary nodes and multiple liver and bony metastases, as you can see on the right as well. In terms of skeletal staging, FDG PET is better for lytic and intramedullary metastases, but may fail to actually detect osteoblastic lesions that can be seen on CT that we do on the CT component of our FDG PET scans. But we all know that whole body bone scans does have a lower sensitivity for lytic metastases. And as you can see in this example here, where the arrowhead points to the osteoblastic metastasis that is extremely, that is taken up on the whole body bone scan, but the lytic metastasis with the arrow is actually not taking up the regular bone scan activity. And in a study of 163 patients with suspected metastatic breast cancer, PET-CT and whole body bone scans were found to be concordant in 81% of patients, with the remainder actually being discordant either in favor of PET or whole body bone scan. And in fact, the only two patients had FDG negative bone scans that were not subsequently deemed as being metastatic disease on biopsy. And when compared with MRI, the addition of 3T MRI sequences, as indicated down here, does actually improve the specificity of MRI compared to FDG PET in terms of detection of skeletal metastases, to a similar level to that can be seen with PET-CT. But of course, the advantage of PET-CT over MRI is the detection of distant metastasis as well. And then also the MRI can also represent post-therapeutic residual scars without active tumor. So some of the pitfalls of FDG PET that it is in general, but also a few specifics in breast cancer that I did want to mention are that of FDG PET and lobular carcinoma, as previously discussed, but also in subcentimeter lesions or sclerotic bone mets, and also false positives in inflammation, infection, and even fat necrosis. This is such an example of a post-operative inflammatory change. You can see on the left chest wall here that has FDG uptake, but these are quite easily identified as being post-operative inflammation rather than being a true false positive PET scan with a good history that's being undertaken. And this particular example as well with the fat necrosis in the left breast here in a patient who has had a history of bilateral mastectomy and in fact had multifocal right breast triple positive cancer treated with chemotherapy. A subsequent PET did show a left breast FDG avid lesion that was identified as fat necrosis on MRI and subsequently on biopsy as well. So in summary for staging, FDG PET really, the role of it would be for that of extra axillary nodal identification and also that for distant metastasis. In terms of recurrent breast cancer, FDG PET is the modality of choice for detecting recurrent disease and in restaging. And in a meta-analysis, the sensitivity and specificity will be very high. And especially if there's a suspicious rise in other tumor markers or even symptomatically, FDG PET would be your first port of call. And in this particular patient here, there is identification of liver and bony metastasis. And I will use this as an example for the further in the rest of this talk as well. So in response assessment, it can actually accurately predict the treatment response even after the first cycle of chemotherapy with significant reduction in the SUV or the actual intensity of the uptake in the breast cancer lesions being detected earlier and was actually indicative of response, and the non-responders were detected earlier, and patients with no change on follow-up conventional imaging. It does show that FDG PET does allow earlier recognition of those who do not respond to systemic chemotherapy. And in that particular patient there, where this the patient did have a FDG PET scan 3 months after commencing her systemic therapy. Not only did we find that there was additional metastases on the right-hand side 3 months later, but there was even the identification of a lytic, new lytic metastasis in the arch of C2 that was FDG avid. So in terms of therapy response, it can help with early assessment of response, which with large declines in FDG uptake predictive of a good response to chemotherapy. We do need to be aware that there can be a temporary flare in FDG uptake seen within 1 to 2 weeks of effective hormonal therapy, but therefore, a good history does not make this a specific problem, and especially if it's been months since the hormonal therapy was started. And in fact, the metabolic flare activity may actually be an indicator of future response to therapy. And in that particular patient, again, after they had a treatment change, we did an earlier PET scan to make sure that she wasn't progressing through that or that she was responding to disease. So you can see that the metabolic burden of viable tumor is improving, although not gone completely. She is headed in the right direction. And this was a very recent scan from this week itself. And in terms of prognosis, the pre-treatment axillary nodal SUV max can actually be an independent prognostic factor in patients with invasive ductal carcinoma. And in fact, a multivariate analysis did determine that the nodal SUV max was a determinant, was the only determinant of the disease-free survival when compared to other factors such as TN stage, ER status, and primary tumor SUV max, which is the intensity of FDG uptake. And in this particular study, you can see that with PET-CT responders compared to PET-CT non-responders, that there is an incremental value for FDG PET in therapy response for patients with metastatic breast cancer. Coming to the end, they're in inflammatory breast cancer in a study comparing MRI with FDG PET and also with mammography. Whilst there was a similar detection rate on MRI and FDG PET, PET again does provide the additional information on distant metastasis and should be considered in the initial staging of inflammatory breast cancer. On a quick note of incidental breast uptake that I know some of you would be referred to for patients who might have had a PET scan for other malignancies or other reasons, there is a 30 to 40% chance of that being malignant, whether that be from a previously unsuspected primary breast cancer, metastasis, or a breast lymphoma. So these should ideally be further evaluated with a mammography and or ultrasound with a biopsy as well. And finally, just talking about the radiation dose in medical imaging, comparing the 3 standard investigations that I've discussed in this talk today. With the combination of CT, chest, abdomen, pelvis, and whole body bone scan, the effective dose is the amount of radiation that is delivered to a patient is between 20 to 25 millisieverts in combination, compared to 8 to 10 millisieverts for PET-CT. And whilst these are deemed as being low risk of additional lifetime risk of cancer, in comparison with a normal daily activity, it's in the same category as that of suffering from a bicycle accident, or actually dying from a bicycle accident is the same category as all these investigations. But I did want to note that for pregnant patients, we can actually modulate the FDG dose so that the estimated fetal dose is actually much lower compared to CT, chest, abdomen, pelvis. And I would encourage everyone to speak to us to discuss the possibility of using FDG PET to stage your pregnant patients when it is required, and we can use our radiation safety officers to calculate these risks as well, specific to your patient. And finally, just a quick word on non-FDG PET tracers, which are all in clinical trials. You may have heard of FES for estrogen receptors, which is good for discriminating disease amenable to endocrine therapy versus more aggressive disease that's unlikely to respond to endocrine therapy. Zirconium labeled trastuzumab for unsuspected HER2 positive metastases as opposed to the HER2 negative primary breast tumors. And also fluciclovine for lobular breast carcinomas that does demonstrate greater FDG avidity and can be used for staging and treatment response. So in summary, what is the clinical impact? I guess for incidental breast lesions, do consider doing mammogram and workup of that. For locally advanced breast cancer, it's important for extraaxillary nodal and distant metastases. It can better evaluate treatment response than a CT or bone scan, and can also be prognostic, and is superior to CT and bone scan for detection of recurrent malignancy as well. But do remember that for early breast cancer, sentinel node biopsy is still the standard of care, and inflammatory breast cancer and triple negative breast cancers are extremely FDG avid. So with that, I end my talk, and thank you all for your attention.
Okay, thanks. That was a lovely talk. We have time for just a couple of questions, and one, these some questions from, I think from Belinda. And it is there data regarding efficiency in low-grade or low proliferation cancers? So the grade 1 cancers, do they behave the same way?
Yeah, so basically grade 1 cancers, they would be less FDG avid, and particularly if they're not proliferating as much, then, you know, they would have less FDG avidity. And pretty much I'd say it is because even when you do a biopsy, you're just taking a sample of one particular part of the tissue. Perhaps if you do a FDG PET first off, and that could be whether I see Belinda's second question there about lobular cancer. If it is actually, if the staging FDG PET is positive, then that can actually be used to follow up all patients in the future. And yes, can you then do away with CT and bone scan? Then the answer is actually yes, and that is part of the rationale behind the approval that we got with from Medicare for using this.
So PET-CT as the sole staging at the time of diagnosis?
Yes, correct. If you're clinically thinking that if you need to clinically stage someone with breast cancer, then FDG PET would be your first off. Okay.
First off, and if negative, no more staging.
If negative, then what we do is that we also look at the CT component to see if there are any other areas. Yeah. And then if there is an ongoing clinical suspicion that they have metastatic disease, then go on and have something else. But
okay. Yeah. And just final question from me before we go on. One thing that concerns me when we introduce a new and more sensitive test is perhaps we are identifying the metastatic disease that can be successfully treated with systemic therapy. Metastatic stage 4 disease essentially equals incurable. So we're taking someone who with normal staging was stage 3, needs lots of treatment, may be cured. But we're saying because we've got a more sensitive test, well, you've got stage 4 disease, that makes you incurable, even though you've got the same disease. How do we know that that is an accurate assessment? Do you understand the dilemma?
If I understand you correctly, you are asking whether the resultant change in management from a more sensitive test is actually the right thing to do for the patient.
Correct. Yeah. Are we denying some people the chance of cure of systemic disease with aggressive chemo by saying, well, it's metastatic disease, we will use a different approach?
I guess to that, I mean, we've got experience from PET in other types of malignancies, and we know from that the change in management can have a significant impact on the management intent, right? So with that, I guess for breast cancer, there is evidence for that, but we know that our clinical practice can evolve with the introduction of new tests. So it would be something I think we do need to be aware of. That we're not actually doing the wrong thing by our patients. Yeah.
Excellent. That was a great talk. Thank you very much. And as predicted, we are going to run over a bit. Thank you for that. We'll now move on to Kenny Elder. Kenny is the breast surgical fellow at Royal Melbourne Royal Women's, finally arrived from Scotland. Kenny is going to talk to us about imaging around neoadjuvant therapy. Over to you.
Okay, can everyone hear me?
Yes, we can.
And we don't appear to be sharing the right screen for the moment. Okay, everyone hear me, and am I sharing the correct screen?
Can hear you and can see you, but not your screen.
Okay, doke. How about that?
Perfect.
Excellent. Okay, well, thank you very much for having me, everyone. As Bruce said, I'm the breast surgical fellow at the Royal Melbourne and the Royal Women's Hospitals, and I'm going to be a surgeon giving you a talk on imaging. So if any of the questions come from radiologists at the end, if we could keep them nice and light, that would be much appreciated. So while all systemic therapy is intended to reduce the risk of distant recurrence, the purpose of administering it is prior to surgery is to downstage the tumour and provide information regarding the effectiveness of response. Downstaging the tumour may allow less extensive surgery on the breast and axilla, including avoiding the risks associated with breast reconstruction, and allow us to undergo breast conservation surgery. The presence and extent or absence of residual invasive cancer after neoadjuvant therapy is a strong prognostic factor for risk of recurrence, especially in the triple negative patients and those with HER2 positive disease. We already know that patients achieving PCR have improved outcomes, particularly those with the triple negative disease. It was hypothesized that overall survival might be improved in the early days of neoadjuvant therapy. However, and actually the early randomized trials have demonstrated equivalent mortality for pre and post-operative delivery of similar therapies. There was a meta-analysis of 10 trials done by the Early Breast Cancer Trialist Group, which showed no significant differences between neoadjuvant chemo versus adjuvant chemo in the risk of distance recurrence. And this, they had a 38% in both arms and 15-year rate. This is however changing, as response-adapted cytotoxic therapy is now associated with improved outcomes. The same trial showed a significant increase in the breast conservation of 65% versus 49%. And within those already amenable to breast conservation pre-neoadjuvant chemo, the associated reduced excised volumes led to improved aesthetic outcomes also. In terms of selection, patients with locally advanced breast cancer, those with stage 3 disease, T3 or T4 lesions are ideal candidates for neoadjuvant therapy, because their cancers are often not amenable to upfront resection, much less breast conservation, and because the risk of distance recurrence warrants systemic treatment. Patients with even smaller triple negative or HER2 positive cancers may be offered neoadjuvant therapy, particularly if they might benefit from additional treatments in the adjuvant setting if residual disease is identified. It is expected that these patients would receive chemotherapy at some point anyway in their treatment course, and these subtypes are associated with a high likelihood of response and PCR. Another indication for neoadjuvant therapy, regardless of the size of the primary tumour, is to downstage the axilla in patients with limited clinically node-positive disease. We know that neoadjuvant therapy can convert N1 patients to N0, especially in patients with more aggressive breast cancer subtypes, and many of these patients can effectively be managed with sentinel lymph node biopsy or nowadays targeted axillary dissection. It can also be an excellent temporizing measure for patients who have medical contraindications, such as those for whom surgery would be anticipated at a later date, women with breast cancer diagnosed during pregnancy, or patients requiring short-term anticoagulation, or in the case of the UK, during a national pandemic when your Prime Minister walks around shaking hands with patients and doctors. However, not all responses are equal, and this is in part due to the challenge of choosing the modality and timing of imaging based on phenotype to best uncover either failure of therapy or likelihood of PCR and everywhere in between. Around 60% achieve PCR in HER2 positive disease, and a third of triple negative patients achieve PCR also. At the other end of the spectrum, hormone receptor positive cancer has the lowest PCR rate, around about 10%. And where multifocal disease is found on initial imaging, it is important that multiple biopsies are required to confirm a similar phenotype, or indeed whether or not some areas may be benign disease masquerading on imaging as invasive or in situ disease. So the assessment of response is of huge importance. Precise evaluation of the lesion allows complete tumour resection while keeping the removal of surrounding tissue to a minimum. In a combined analysis of 6 studies, physical examination had a 50 to 60% positive predictive value. That is the ability to correctly predict the presence of residual disease at final pathological examination. But challenges with physical examination include the presence of firm fibroglandular tissue and post-therapy fibrosis, which can often overestimate the amount of residual disease. Likewise, interval loss of palpability after treatment does not exclude the presence of residual viable tumour either. Mammography has been shown to be more sensitive than physical examination for detecting presence of residual tumour after therapy, but is less specific and may underestimate the degree of treatment response. Additional challenges with mammography include the presence of microcalcs, which did not always correlate with the presence of viable tumour. Ultrasound has been shown to be a better predictor for pathological tumour size than mammography after treatment, but again can often overestimate the size of the viable tumour by measuring the remnant tumour bed in its entirety. MR is currently the most accurate modality widely available, with a positive predictive value of over 90%, yet the negative predictive value, that is the ability to correctly predict the absence of disease at final path, was only moderate at 65%. Despite this, MR does not yet have the proven accuracy to allow for no surgery when demonstrating a complete radiological response. So I've got some lovely pictures given to me by our consultant radiologist and panel member today. So here we have an example of an MRI for a 36-year-old female with a 4-centimeter tumour in the left upper outer quadrant, which enhances nicely on MR, as does a prominent lymph node, which you can see towards the right-hand side there, and was actually benign on FNA. Following completion of neoadjuvant therapy, under the blue line there, we can see that there's been partial response and the tumour has reduced in size. This was accurately predicted by the final MR scan, and the patient went on to have a wide local excision demonstrating a 17mm grade 3 triple negative breast cancer. So the prediction of response and doing so in a timely fashion is of the utmost importance. Knowing early in the process whether a tumour will be unresponsive or achieve PCR or everywhere in between can have a significant impact on outcomes. A Dutch collaborative looked at patients recommended for neoadjuvant chemo over 3 years in Maastricht. They investigated MR at the start of treatment, midway through, and at completion. They found that 25% of tumours were stable or had progressed, and 10% had demonstrated PCR radiologically had residual disease at final pathology. Of note, they demonstrated that timing of MRI is important also. MRI-based response patterns halfway through neoadjuvant chemo predicted pathological response much more accurately than MR-based response after. A complete radiological response halfway through was associated with 83% PCR, while a complete radiological response after only seemed to be correct in 41% of cases. This suggests the current protocol in some centres with MRI at the beginning and towards the end of therapy misses an important early opportunity to either modify the cytotoxic therapy or plan for early surgery if PCR seems to be unlikely. Similar outcomes were observed in a sub-analysis of the imaging in the German ADAPT trial. They suggested that response as early as 3 weeks evident on imaging was highly predictive of PCR. There are, however, some factors which affect the use of MR. Long-term patient survival outcomes are not yet known, and has been speculated that finding small additional tumours, albeit true positives at MR imaging, will be unlikely to alter the mortality, since they may be effectively treated with chemotherapy and or radiation therapy, as Bruce briefly touched on it in the questions at the end of the last talk. On the other hand, there is some concern regarding the potential delay in definitive treatment caused by detection of false positive lesions, requiring time-consuming additional imaging plus or minus biopsies. Several studies have already identified the accuracy of MR imaging in determining residual tumour size after therapy differs across subtypes. It is greatest in ER-negative, HER2-positive and triple-negative tumours, and is less accurate in luminal tumours, which mirrors the overall response itself. The type of chemotherapy regime can also influence diagnostic accuracy of MR, which can underestimate residual disease, particularly in patients treated with taxanes. The pattern of tumour response can also impact accuracy. MR imaging can underestimate residual disease when fragmentation occurs, or overestimate residual disease if there is a response of reactive inflammation and fibrosis within a tumour bed. So to increase accuracy, we look at functional tumour volume, that is the size of the biologically viable cancer, where functional tumour volume is a computer estimated volume using signal enhancement ratios. The I-SPY 1 trial investigated functional tumour volume and found that it predicted PCR and recurrence-free survival very accurately. I-SPY 2 went a little further and was a retrospective analysis of around 400 patients stratified by hormone receptor and HER2 status to test the prediction models combining multiple MR features outperform models with single features alone. 4 features were quantitatively calculated in each MR: functional tumour volume, longest diameter, sphericity, and contralateral background parenchymal enhancement, BPE. In the full cohort, with all cancer subtypes analysed, the area under the curve for the combined model was 0.81 that you can see there. Importantly, each of these features can be measured from a standard MRI dataset, so no additional images are required. Other modalities have in the main only been investigated in research and not day-to-day clinical practice, but may in the future play some role. A number of meta-analyses have been conducted investigating PET as a modality for assessing response to NAC, and all estimate high sensitivity in the range of around 80%. They have moderate specificity with a range of around 60 to 80%, and the negative predictive value for non-responders was around 90%. And compare this to what I said earlier about this being around 60 to 65% in MR. Thus, PET imaging could potentially be used as an early in vivo test of chemosensitivity. Overall, however, at present, it is deemed not sufficiently spatially sensitive enough for detecting residual disease to be used in routine assessment. FLT PET has been developed as a proliferation tracer, and given that proliferation is a key biological marker for therapeutic efficacy, it may therefore provide a better marker of early response than glycolysis. Contrast-enhanced mammography has by far the greatest potential to rival MR as the imaging of choice in assessing NAC response. A small study by Lotte et al. Showed that MRI and CEM, or contrast-enhanced mammography, lesion size measurements were highly correlated, and it seems to be at least as reliable as MR in assessing the early response to therapy. May also indeed be an alternative or a rival to MRI. So more of the in-house pictures from the Royal Women's. Here's an example of the use of contrast-enhanced mammography before and after neoadjuvant chemotherapy. A 69-year-old lady with biopsy-proven multifocal disease from screening with the disease at 11 o'clock and 1 o'clock was triple negative on both cores. We can see particularly in the CT views that the 1 o'clock lesion is easily seen, but that the multifocality is far clearer on the contrast-enhanced pictures in that third column. The post-treatment mammography pictures show reduced masses and unlikely complete response, yet the contrast there appears to be evidence of complete radiological response. So the contrast-enhanced mammography predicted PCR, and on final path, this was indeed the case. Interestingly, the final accompanying ultrasound in the top hand right corner queried residual disease also. So in terms of assessment of the axilla, first of all, multiple studies have shown there is no role for imaging the axilla during treatment. An ultrasound should be done at the end of therapy, however. The Z1071 trial evaluated the accuracy of axillary ultrasound in around 600 patients who presented clinically with N1 or N2 disease and underwent ultrasound, sentinel node biopsy, and axillary clearance following neoadjuvant chemo. The major findings were that patients with suspicious nodes on post-treatment ultrasound were very likely to have positive nodes at surgery, and they showed this to be around about 70%. Increasingly in some centres, however, nodal response can be adequately assessed with an axillary coronal MR as part of the final imaging programme. The much talked about data from the MD Anderson demonstrated that targeted axillary dissection, the combination of targeted lymph node biopsy and sentinel lymph node biopsy, can reduce false negative rates down as low as 1.4% if the clipped and sentinel nodes were removed. In any case, they also recognise the clipped node will be identified as one of the sentinel nodes in around 75% of cases. This accuracy might be further advanced with improved localization of clipped nodes over the conventional search for the clipped node and then have a look in the Faxitron method. MagSeeds have shown excellent localization of clipped nodes in small-scale studies and are now licensed for long-term placement, so it can be inserted at initial biopsy. The downside is significant artifact on MRI, and this can extend to around 5 centimeters, rendering MRI assessment of nodes impossible. So in conclusion, the ability to use non-invasive methods to accurately predict PCR early in the course of treatment has enormous clinical implications, as it would permit personalized evidence-based escalation or de-escalation of therapy. The future may well be no surgical excision at all, where PCR is demonstrated and be replaced by a large volume vacuum-assisted biopsy or normal biopsy of the residual tumour bed only. With respect to the timing and modality of imaging, the research points to an MRI or contrast-enhanced mammogram before and early during the neoadjuvant therapy to identify patients who are not benefiting and direct them to alternative systemic therapy, or proceed with surgery itself. This should be repeated after therapy to aid in final surgical planning. This should also be accompanied by axillary ultrasound, or as I mentioned, coronal MRI of the axilla. Ultrasound assessment of PCR and final tumour response is known to be poor. The modality and specific timing may well require tailoring to the specific molecular tumour subtype, as shown in the I-SPY2 trial, and the type of neoadjuvant therapy planned. This will require future trials to address these aspects with multiple arms. And finally, how close are we to the holy grail of no surgery at all in the excellent responders, with imaging techniques proven to be accurate enough in determining PCR that perhaps simply an end of treatment tumour bed biopsy would suffice? Thank you very much.
Okay, thanks, Kenny. That's a lovely presentation. Do we have any questions? So in summary, your recommendation from the review of the literature is for some form of contrast imaging at diagnosis early during chemo, particularly if response or non-response will change management, and then towards the end of chemo. Is that correct?
Yes. So, I mean, it would likely be that in most centres, the MRI would be what we would have kind of pre-treatment. And in a lot of places, and particularly around where I've come from, the UK, we would hold off an MRI, or save an MRI, if you will, to do one right at the end of treatment. And that's almost definitely shortchanging some patients who we found in the final MRI to have not responded particularly well, or as I said about the inaccuracy of clinical exam, those that we thought were responding but in fact weren't responding, and we could have had that opportunity to either get to surgery early or change the therapy itself.
So can I ask Belinda to comment here? Why are we at a stage that we will change the treatment depending on the early response? Because I don't think I've seen that or very often at all.
So I think very early on in the treatment path, within the first cycle or so.
No, after about 2 cycles. I think Kenny suggests after 2 or 3, if it's AC, then Taxol. After 2 or 3 ACs, are we ready to change treatment based on lack of response in particular?
I think, let's take progression out of it because that's easy. But when you say lack of response, I think in the triple negative setting, if you've got significant residual disease after 2 or 3 cycles, there is a motivation to give them extra in the second half of their chemotherapy. So that certainly is probably the first place that comes to mind. But the risk here is that you're making an assessment a little too early. But I think certainly in triple negative disease after 2 or 3 cycles, substantial residual disease at that point really does make you worry. And we know, I mean, Shireen's got data to show that those patients don't do as well. And they're certainly the ones that have gone into some of the IO studies, and maybe the ones you'd add in things like carboplatin. So, yeah. So
it might be in the future, things will change so that very early response adapted therapy will happen, but it's barely investigational right now.
Yeah, I mean, I think where potentially you could really take this, and I'm sure there's some data in this, is, you know, in more the patients who you're trying to withhold chemotherapy for, and you're looking for good, you know, molecular imaging responses by perhaps using some endocrine maneuvers in the ER positive setting. And if you get very early signs of that response, that might reassure you to withhold chemotherapy. But I don't think from a clinical point of view, without a clinical trial, we're really up to that. Can I ask, which I'm embarrassed to ask this in front of this audience because I should know this, but in, you know, a patient who's got locally advanced disease, maybe ZTing, I should have petted her, but say I've CT'd her, she gets contrast with that, she gets contrast with a mammo, she then comes back and has another mammo, then has another contrast mammo, then she might get a CT angio because she's going to have a recon. So there's a lot of contrast in there. Do I need to be worried about that over the course of a few months, or is that just me being very naive?
Different sorts of contrast, no problems with the MR because we all use macrocyclics now. so that's not deposited anywhere. Iodine is, as you know, we use it widely for CT and contrast mammography, and it's fine unless there's renal impairment. And even then, the EGFR has to be less than 30 for there to be real concern, and that's very low. And I can't comment on FDG.
FDG PET does not affect the kidneys, and vice versa. Yeah.
Okay. Well, thanks.
Okay, so reassured, you can go away happy. All right, thanks, Kenny. That was very good, and I think the lesson to me is that as a group, we should standardise our imaging around neoadjuvant, and you have identified a potential way forward.
Could I, sorry, Bruce, could I
yes,
just make a little plug for an exploration at some stage, if we do continue as we are, to try for some large core VABs with MR or stereotaxis of the beds in people who've had unifocal but very responsive tumours who have complete responses.
Yeah.
Instead of surgery.
Well, and there are some series who've done that, and I think the question is whether from a medical oncology point of view, we are comfortable that such a patient who looks like she's had a PCR does not need follow-up different chemo. Requires a trial. All right. So we'll now ask Jenny Ellis to talk to us about contrast mammography, which is something that is really very exciting. Jenny.
Thanks very much, Bruce. So I'm talking about contrast mammography, and I was going to start just by running through how it's done for those that aren't doing it. So all the images in contrast mammography are taken after the injection of intravenous contrast. But we're able to produce what looks to be a non-contrast image by using two different levels of X-ray energy beam. So on the low energy beam, it looks like a standard 2D mammogram, and the X-rays are not absorbed by the iodine at this level. And then the high energy beam, at this energy level, the contrast does absorb the X-ray beam, although you can't particularly see it on the high KEV image. But when you subtract the two images, you get a contrast only image. So what we do is the patient gets an IV line, they get 100 mils of iodinated contrast, the same way you do a CT scan, given at 3 mils per second with a pressure injector. And then you wait for 2 minutes, and then you take them into the mammogram room and you just do a standard set of mammograms. But it's able to produce these sets of images where you get a standard looking 2D mammogram and a contrast only image. And this is just the absorption of X-rays by the iodine, and you can see that at a point it changes from being not absorbed very much by the iodine and then absorbed at a high level at a high energy spectrum. Now we know from MRI that virtually all cancers enhance post-contrast injection, and the ones that tend not to enhance are the low-grade cancers like low-grade DCIS or low-grade invasive disease. And so the enhancement with contrast is actually quite an important prognostic sign. So compared to mammography, where it tends to be better at detecting low-grade disease. So this graph, you can see that MRI is more sensitive for both low-grade and high-grade disease, but it's particularly sensitive for picking up high-grade DCIS and high-grade invasive cancer, compared to mammography, which performs better with low-grade DCIS and worse at higher-grade disease. So the addition of contrast is really important for picking up the prognostically important tumours. And this is just an example of what contrast mammography looks like and how important it can be, particularly in the setting of dense breasts. So this was a 62-year-old lady who came in with clinically suspicious lesions bilaterally, and as you can see on mammography, extremely dense breasts. She had quite indeterminate findings on ultrasound. But with the addition of contrast, it becomes much easier to see that in the left breast, she has a rim-enhancing mass with adjacent non-mass enhancement, which is the invasive disease and the adjacent DCIS. Whereas on the right breast, there is no abnormal enhancement. And this was all confirmed to be benign, even in the area of clinical concern with a surgical biopsy. So it's a very good predictor of, so it's got good positive predictive value. So contrast mammography has been around since 2010 when it was introduced in Europe, and in the US in 2011. And early studies support the use of contrast mammography being more sensitive than mammogram and ultrasound alone. It has a similar sensitivity to MRI. It's slightly less sensitive for additional foci of disease, but it has better specificity. It's also easy for radiologists to read, and in fact the specificity and sensitivity was better with contrast mammography independent of reading experience of the radiologist. And it's also preferred by patients because it's quite a short examination in an open mammogram unit. It's more tolerable, particularly to people who have claustrophobia. So we've been performing contrast mammography at the Royal Women's since 2015, and we initially started using it for a small number of indications, particularly problem solving or cancer staging, and in screening where the patient was not eligible for screening MRI. But as we continued the use and we found it very useful and easy to read, we expanded our patient selection and now offer it to all patients who attend to Royal Women's for mammography. So that means our patient selection is really moderate to high risk screening population, as well as follow-up of known cancer and evaluation of symptomatic disease. When Bruce asked me to do this talk, he suggested that we talk about the indications for the use of contrast mammography. And I took it from a very radiological perspective of, well, what are the indications for the use of contrast in general? Well, X-rays were invented in 1896, and we started using contrast in 1896 to try and improve the diagnostic ability of imaging. Iodinated contrast, like we use in today, has been around since 1920 when it was used for renal imaging and angiography. And the low osmolarity non-ionic iodinated contrast that we use today has been around since 1974, and it's used extensively in CT. And in fact, the indications for a non-contrast CT would be small. So when I look at, well, why should we use contrast in mammography? It's the improvement in diagnostic sensitivity suggests that all mammography should be performed with contrast, particularly in the hospital-based setting where there's already a CT scan in place and there's not really that many barriers to its introduction. So what are the barriers to the use of contrast? And there are a small number of risks associated with it. There is the risk of anaphylaxis, which occurs in less than 1% of cases and is usually very mild, just with urticaria. Although occasionally people can have a severe anaphylactic response and would require adrenaline resuscitation. And so one of the barriers to contrast mammography is really in screening. And if you think about screening centres where there's a breast screen on the back of a van that drives around country towns, or breast screen at the Rose Clinic at David Jones. Use of contrast mammography in those settings is more difficult because you have to be prepared to cannulate a patient, to have adrenaline on hand and resuscitate if there's a severe anaphylaxis. The other barrier to contrast administration is the risk of contrast-induced kidney injury. I think, as Alison pointed out before, it's really uncommon and only substantial in a patient who has an eGFR of less than 30. Although radiology departments, because of this, have indications for getting blood tests to check a patient's eGFR before administering contrast. And that's usually in any patient over 65 or with a history of potential renal impairment. And so that is also going to be an issue of screening if you need to know what the renal function is prior to administering contrast. The risk of extravasation of contrast of media into the soft tissues at the time of injection is small. If you had a very large volume of contrast extravasating the soft tissues, it can, in theory, cause tissue necrosis, but this is very uncommon. Usually it's a small volume of contrast is extravasated before it's identified, and mostly it's mild and resolves with conservative treatment. So I'm talking about contrast mammography at screening, particularly because of the DENSE trial, which was published last year, and they were looking at population risk, women with extremely dense breasts, and using MRI for screening. And as you can see, the cancer detection rate with MRI is substantially improved compared to mammography. And importantly, the interval cancer rate was much lower. So we know that these are detecting prognostically significant cancers. And I've borrowed this slide from Mann because after the results of the DENSE trial were published, the Dutch Parliament realised that they had to act on the results and offer MRI screening to low-risk women with dense breasts. And so now they have to go through the process of working out what a screening program looks like with the addition of MRI. And so they were proposing perhaps to introduce MRI into the low-risk women with BI-RADS D density breasts. But of course, because of the expense of MRI and relative lack of access, it might have to be performed every 4 years to make it viable. Equally, MRI is used in a hospital-based setting in intermediate and high-risk women. So we're in considering screening and when it might be appropriate to use contrast mammography or MRI, the risk factors that we look at are the genetic risk factors, and women in this category tend to have a high risk and will commence high risk screening with MRI at a younger age. But then you have the moderate risk women with a family history or personal history of breast cancer, high risk lesions such as LCIS, and then we have these issues of the increased density and the unknown role of background parenchymal enhancement as a risk lesion in itself. So how could we include contrast mammography in screening in Australia? I think it's probably more likely to be accessible than MRI, even with the introduction of abbreviated MRI. But if we have low-risk screening of dense breasts in a screening setting, including contrast mammography, we need to overcome those barriers of contrast administration in a breast screen setting. We could also use contrast mammography more in screening, and perhaps the high-risk women, instead of performing annual MRI and mammography simultaneously, maybe we could alternate contrast MRI and contrast mammography. So this hopefully will be introduced more widely, but there are barriers to its introduction. Thank you.
Thanks, Jenny. That's a very nice presentation. Do we have any questions? Anyone who has questions, please use the Q&A or the chat function. Can I ask the question, what about the older ladies? When you've got the older patients, they have often got low breast density. You have to get an EGFR and cannulate. Is there an age beyond which it's really not necessary and we should just rely on standard mammography?
Well, certainly. So our policy is anyone over the age of 65 needs to have their renal function tested beforehand. And it is a barrier to contrast mammography, although you would say that these people still have quite a long life expectancy in many cases. And so it seems unreasonable to exclude them based on age alone. Dr.
Alison?
The College of Radiologists has put out a set of guidelines. I'm working on it currently, where they say that you should not actually withhold contrast on the basis of age alone. And the EGFR goes down with age anyway, so it's pretty unreliable. Most of the women we see in screening, for instance, are ambulatory. Those that we see for, monitoring after cancer and all of that sort of thing, they usually have an EGFR. So I'm working on getting rid of that particular thing, unless they give a history of renal impairment, would have to be substantial, or diabetes on metformin. Basically, I think we shouldn't be doing EGFRs. The cannulation is not a problem. We have quite a few 80-year-olds who've had contrast and it's helped. They're not all fatty. Some of them are fatty and they have disease that you simply can't see on contrast. The gap between contrast mammography, which is almost as sensitive as MR, but a bit more specific, and conventional imaging, that's tomo, mammo, ultrasound, in detection is of the order of probably 8 to 10 cancers per thousand. The dense trial, that 16.5 cancers per thousand was incremental over the background population of 6.8 per thousand. So it's a terrific test. And if they're well enough to get an operation from you, they're actually well enough to have a contrast mammogram from us without an EGFR, unless they've got some reason.
Or another way of putting it is, if they're well enough and require surveillance or imaging, why not do the most sensitive imaging?
That's the one.
And the issue of sorting out the indeterminate additional lesions, I don't think that's been covered much.
There's no biopsy for contrast mammography yet. It's been released in Europe and it's very similar to tomo biopsy. So we'll have it in Australia, I think, by the end of this year. It will be a game changer, because at the moment we have to do it with MR, and I suppose an 80-year-old on an MR scanner might have a number of implanted devices by that stage, which precludes the biopsy. But we'll have contrast biopsy soon and it will be a game changer. We'll be able to do those things quite easily, I think.
Okay. Any questions we have? So a question here seems a huge difference as to public versus private and who gets contrast enhanced mammography. Is that due to funding? I may have missed this. I think the answer is there is not much.
No.
It's probably more the setting. So certainly around Parkville, there's no public-private difference. Is that correct?
That's correct. I think a lot of the issue is around the cannulation, but I think you can actually charge a fee for a cannulation if you're in a private practice. A bottle of contrast, when you use it like we do in CT and they deliver it by the sort of milk tanker almost, is about maybe $10. I think there's a little bit of fat in the thing that would allow you to perhaps extend to that.
Yeah. All right. Any other questions? in which case we have gone a little over time. I think this has been a really great session. Thank you to all three speakers. There's a lot in this, a lot is happening, and just over the last, well, each year things seem to have changed, so I'm sure we could revisit this again in a year or two. A reminder that our next session is going to be on oligometastatic breast cancer from various points of view, medical, radiation and surgical point of view, and it's going to be on, let's see, I think it's May the 26th.
That's right.
Delayed a little because of the College of Surgeons meeting, so please put it in your diary, May the 26th. And I'd just like to thank all the speakers and panelists. Really good session. Thank you.
Thanks very much, guys. Thanks, Bruce.